Hi, everyone. We're so glad you could take time out of your day to learn about the latest in stroke assessment, triage, transport, and treatment. My name is Faith James, and I'm with the Society of NeuroInterventional Surgery, which is an educational association of neurointerventionalists, and they diagnose and treat issues with the head, neck, brain, and spine. So stroke, of course, is right up their alley. And our presenters today are actually speaking on behalf of SNIS's Get Ahead of Stroke campaign. And you'll learn a bit about that as we go through the presentation. But just the top line is that we are SNIS's advocacy and education campaign to improve stroke systems of care. And we were launched in 2016 and have been doing state legislation updates alongside EMS partnerships and education and consumer or general public education about stroke. So I will introduce Dr. Mahesh Jayaraman. He is the president of SNIS, and he will also introduce Dr. Johanna Fifi.
Okay, thank you, Faith, and thanks everyone for logging in. We're really excited to have you guys and speak about stroke. We're all very passionate about it. As Faith said, I'm Dr. Mahesh Jayaraman. I'm the current president of SNIS, and I'm an interventional neuroradiologist practicing in Providence, Rhode Island. And my co-presenter is Dr. Johanna Fifi, who's an interventional neurologist who practices in New York City. And she's the president-elect of SNIS. I'm going to have Dr. Fifi take the first portion of the presentation. I'll give the second portion. We're both available for any questions. I have the chat open or Q&A. And thank you again for taking your time.
Hey, thanks, Mahesh. This is it's great to have the opportunity to present to you guys, as you're the front line for our stroke patients often. So in this talk, the learning objectives for this webinar include reviewing stroke prevalence in the U.S. and the different types of stroke and treatments. We're going to discuss the purpose of stroke scales and pre-hospital management for ensuring successful patient outcomes, and then go over some of the latest research on thrombectomy, which is a procedure we do to treat the most severe of strokes, and how this benefits from severity-based triage and transport of patients. And then we'll review some tools and resources that you can use. Next slide. So first, I'm going to go over the stroke in the U.S., just a general overview. Stroke is a leading cause of death and long-term disability in the United States. Every 40 seconds, someone in the U.S. has a stroke. There are more than 795,000 people having a stroke in the U.S. every year, and it kills about 140,000 people. So that's 1 out of every 20 deaths. The vast majority of strokes are ischemic strokes. That's caused by a blood clot in the brain, blocking off a blood vessel that supplies the brain, as opposed to the smaller percentage is hemorrhagic strokes, which is bleeding into the brain. Next slide. And so this is a map of the United States looking at deaths caused by stroke. And you could see the darker purple are the really high rates. And that's why the South is often called the stroke belt. So a lot of the deaths due to stroke are concentrated in our South. In the Northeast, where I happen to practice, it's a little bit less, but still very prevalent. Next slide. So ischemic strokes, they typically present with a neurological syndrome, and this syndrome depends on the location in the brain where you're having the lack of blood flow. So if it's the left hemisphere, that's where patients will present with a left gaze preference, not being able to see in their right visual field, weakness of the right side, loss of sensation in the right side, and often actually with language problems. On the right hemisphere, you have a right gaze preference, left visual field deficit, and then left-sided hemisensory loss and hemiparesis or weakness. When strokes occur in the back of the brain, so in the cerebellum, you can get ataxic gait, so trouble walking, trouble moving your limbs, with trouble with coordination, limb ataxia, and then neck stiffness. In the brainstem, that's the trunk of the brain, that can be very serious and often a confusing syndrome, as it can be, it's hard to distinguish from other things, but you can have nausea, vomiting, double vision, dysconjugate gaze, slurred speech, vertigo, tinnitus. You can have weakness on one side of the body or all four limbs, sensory loss, and then eventually, if as a progressive, decreased consciousness, and trouble with respirations. Next slide. So hemorrhagic stroke, you can have focal deficits, all of the things that I just went through, depending on where in the brain the hemorrhage happens. Typically, it's accompanied by headache, especially in subarachnoid hemorrhage, a very severe headache, neck pain, light intolerance, and then nausea and vomiting, and decreased level of consciousness is often more common in hemorrhagic strokes. Next slide. So patients, when you're evaluating a patient in the field, some of the things you might hear in the past medical history that are risk factors for stroke are high blood pressure, smoking cigarettes, diabetes, if they have a history of actually plaques in the carotid, if they have peripheral artery disease, atrial fibrillation, other heart disease, sickle cell disease, high blood cholesterol, poor diet, and physical inactivity and obesity are also risk factors. Those are all things that you can modify. Things that you can't really control: increasing age is a risk factor, family heredity is a risk factor, then race, gender, and prior stroke, TIA, or heart attack are also risk factors. Next slide. And important to note that there's stroke mimics, so things that could be mistaken for a stroke. Hypoglycemia can present with focal neurological deficits, and things like mass lesions in the brain, seizures and post-ictal states. A migraine sometimes can mimic stroke. Some patients have what we call functional hemiparesis, that can mimic a stroke. Encephalopathies and other toxic metabolic conditions, like alcohol or drugs, can mimic stroke. Next slide. So we have these scales that are often used to try to tease out amongst the many patients that you see day to day answering EMS calls, how to distinguish the small percentage that have stroke. And so over the last couple decades, there's been development of kind of quick, easy scales that can be used in the field. Some examples are the LA Motor Scale, LAMS, or CSTAT, MEND, the FAST ED scale, Cincinnati Pre-Hospital Stroke Scale. If you guys don't mind, if you can put what kind of scale you use in the chat here. I'm just taking a look. Someone said they use BFAS and cortical signs. RACE score is also a scale. For next slide, I'm just going to go over, in New York City, we actually use a modified version of the LA Motor Scale. It's the LA Motor Scale plus one more category for speech, SLA. It's called SLAMS. So I'm just going to review the LA Motor Scale for those who aren't familiar with it. It's basically taking a look at the patient's face, having them smile, get 1 point if one side is weak or flaccid, and then looking at the patient's arm, having them hold it up, 1 point if one side is weak, and 2 points if one side doesn't move at all. And then the grip again, 1 point if it's weak and one side doesn't move at all. And then if you have 4 points, or if you basically have over 4 points, that's an over 7-fold increase in the risk for having a large vessel occlusion, which is the most severe type of stroke. Next slide. The Cincinnati pre-hospital stroke scale is also very similar. Again, facial droop, arm drift, and speech. This one includes speech, so the patient can talk normally, or the patient slurs words or says the wrong words or is unable to speak. And so it's a screening tool for strokes, and if one or more of those elements are abnormal, then the patient screens positive. And New York City EMS does use this as a screening tool, and then the other scale I mentioned to distinguish between large vessel stroke and smaller strokes. Next slide. So once you determine the patient is likely having a stroke, bring them to the emergency department, and we'll talk later on in the webinar about triage and where to take them. But what you should know to report is patient's age, sex, and weight. The weight is important because one of the treatments is TPA that's administered by weight. And then also reporting injury or medical problem. This is just a kind of generic, but chief complaint with brief history of what's going on to the patient, and then vital signs, the level of consciousness, general appearance, if they're in distress, the cardiac rhythm, regular atrial fibrillation, and then any medications that are given in the field. And then basically, in New York City, the estimated time that you're going to arrive is important. We've gone to a system of pre-notification. So if we get a notification from an EMS unit that they're bringing in a patient with a stroke, all of the stroke team is notified before the patient arrives. So it's important to notify the receiving facility as soon as possible. Next slide. So in the pre-hospital arena, or in the field, it's important to assess the airway, basics for everybody, ABCs, breathing, circulatory status, important to check the blood glucose, look for mimics, and then obtain full set of vitals, review, try to obtain the patient's medication list, perform the EKG, and establish IV access. And as we know, the intravenous thrombolysis can be administered in certain patients in the first 4.5 hours of onset. So very important to try to ascertain the patient's last known normal in stroke as well. But any history of any contraindication for thrombolysis is important. So active internal bleeding, recent surgery, especially intracranial or intraspinal surgery, or head trauma, any conditions that may increase the risk of bleeding, bleeding diathesis, current severe uncontrolled hypertension, current hemorrhage, subarachnoid hemorrhage. All of these are reasons that you would not give IV thrombolysis, and it is important to know about. Next slide. And IV thrombolytics are important, but they don't work most of the time. They don't work for patients who have severe stroke, and those are the patients that have emergent large vessel occlusions, ELVO or LVO, You'll hear this term a lot in speaking about stroke. And those are patients that have a clot in one of the large blood vessels leading up to the brain. And for those patients, next slide, you can do a procedure to treat them. These are examples, these are angiograms looking at where you can have these occlusions in large vessel occlusion stroke. So on the left side, it's we're looking at the patient and you can see the internal carotid artery going up and then a cutoff in the middle cerebral artery. So for these, the recanalization rate with intravenous is 22%. And really the mortality if untreated is 25 to 42.9%. So these are very serious strokes. In a basilar occlusion, that's the blood vessel that goes to the base of the brain. Recanalization rate with TPA is less than 10%, and mortality in this type of occlusion is very high, 90% if it's not opened up. In a carotid occlusion, so the right side, you have the similarly recanalization rate less than 10%, and mortality is about 73% if not opened up. So these are the most serious type of strokes. Next slide. Most serious type of ischemic strokes. And the procedure that we perform to treat these patients is called thrombectomy. This is an interventional procedure where we use catheters to quickly reopen the blocked arteries of the brain. Nowadays, it used to be that these procedures would routinely take a couple of hours, 2-3 hours, and in that amount of time, brain tissue is dying, so it wasn't as successful. But now, in the last decade, really, the procedure can be done in less than 20 minutes for a lot of patients. So, in this procedures have been tested in randomized trials where patients were randomly assigned to either having a thrombectomy or having medical management, and this shows that it's shown time and time again in multiple randomized trials all over the world that this procedure significantly improves outcomes in patients with internal carotid artery occlusion and M1, and now also in posterior circulation or basilar stroke. Next slide. And so, the important thing though is that the procedure has to be done very quickly. And this is a great paper from many years ago, but the truth is still there that time is brain, and that's often you'll hear us saying that basically if you're having a large vessel occlusion and the brain is not getting blood flow, you're having death of 1.9 million neurons per minute. And so this is why all of the focus is now on pre-hospital care and getting the patients to the right place so that this procedure can be done as quickly as possible. And at this point, I'm going to turn it over to Dr. Jayaraman, and he'll go over triage.
Okay, so thank you, Dr. Fifi. And so you heard from Dr. Fifi about how time-sensitive stroke is, right? We're losing 2 million neurons a minute. And the brain is aging years for every hour without blood. Now, thrombectomy is incredibly effective. It's a very, very effective treatment. The problem is that the teams needed to appropriately do thrombectomy involves not just a neurointerventionalist, such as myself or Dr. Fifi, our procedural team. This includes nurses, technologists. Sometimes we have residents or fellows who are doctors learning how to do these procedures. Other times we use nurse practitioners and physician assistants. There's an anesthesia team that's often available. And then in addition to that, you have to take care of the patient during their hospital stay. So this includes dedicated resources like the neuro ICU and dedicated neurologists who are able to care for these patients. So as you can imagine, the resources needed to do this correctly are not available at every hospital. So many times what happens is the patient first goes to a hospital is the patient first goes to a hospital that is not able to do thrombectomy. So we call these primary stroke centers. And then secondarily, they have to be transferred to a comprehensive stroke center. And just as I'm typing, if you guys can indicate in the chat how many of you had to do this sort of interfacility transfer. Well, the problem is these transfers take time. And if it takes too long, by the time they get to the comprehensive stroke center where the thrombectomy can be done, they'll have a big amount of completed stroke. There won't be any tissue we can save. So if we look at the next slide, what we did here in Rhode Island and southeastern Massachusetts, so where I practice in Providence, we have a very unique situation. The state of Rhode Island, which is about 60% of our patients, we decided to triage in the field. And we started this way back in 2017, where we started mandating that patients who had a LAMS of 4 or 5 had to go directly to the comprehensive stroke center. But about 40% of our patients are from nearby Massachusetts, right on the border. And those situations, those patients go first to the primary stroke center, they wait, and then they have to go to the comprehensive stroke center. And so what we found is over 5.5 years, the time to treatment in Rhode Island plummeted. It dropped by nearly an hour. It's about a 40% decrease in time to treatment. Meanwhile, in Massachusetts, without triaging in the field, there was 0 minutes of change in 5.5 years. So just think about that. Everybody knows stroke is time sensitive. Everybody knows how important it is to treat patients quickly. And yet, despite all these efforts, there's no change in time to treatment over 5.5 years. And when we looked at the data and the clinical outcomes, there was a significant benefit to the patients who were treated with thrombectomy in Rhode Island compared to Massachusetts because they were being treated an hour early. Next slide, please. So the degree of benefit is really profound with thrombectomy, right? And initially, when we first did these trials back in 2015, we were focused on what we call the early window, the first 6 hours. We've had additional trials that have shown that this treatment is remarkably effective up to 24 hours from last known normal. So it's not just of the first 6 hours. Despite that, it's almost like you can reset the clock from the time the patient calls 911. Every minute from when they call 911 to the vessel open is meaningful, right? And the more quickly we can do this, the better. So if we look at some statistics for patients, right, increases their life expectancy by 5 years. Think about that. If you can get thrombectomy in a timely manner, patients can live 5 years longer. That's amazing. A patient that gets timely thrombectomy is twice as likely to be alive and independent at 90 days after a stroke. Again, a remarkable treatment benefit. And just to give you an idea of how quickly that minute saved is, for every minute faster we can do thrombectomy, patients gain a week of independent life. So if you think about it, and I talked about how we were saving an hour with going directly to comprehensive stroke centers, you're giving every one of these patients back a year or more. Can we go to the next slide, please? So ideally, all patients would be treated at a level 1 stroke center, comprehensive stroke center, which has the full. If there is no level 1 stroke center within 2 hours of patient location, then we think it's helpful to have these, what we call thrombectomy capable stroke centers or level 2 stroke centers in a more rural areas. These are centers that can do thrombectomy, but perhaps can't take care of the hemorrhagic strokes, the patients with hemorrhage from brain aneurysms, and more complicated diseases. Go to the next slide, please. So what's the challenge? The challenge, and this is where you guys come in, less than a third of eligible stroke patients get thrombectomy. And while we've made a lot of inroads with our efforts, many states still do not have protocols for first responders. And I'm just looking in the chat, it looks like some patients, some of you are in places with tiered triage protocols, which is great, which is what we're advocating for. Next slide, please. So what are the solutions, right? And so we think the most important thing is to take patients who have a suspected large vessel occlusion, suspected elbow, in the field to the closest and best hospital, right? In some cases, the best facility for that patient is not the closest. And so what our campaign has been working on is updating EMS protocols in all 50 states. We've been educating clinical leadership and EMS professionals about the assessment and triage of these severe stroke patients in the field. And like Dr. Fifi was talking about with these stroke scales, different stroke scales are available. Different regions may pick different scales. They're all pretty similar. What you're trying to do is not just say, is this a stroke? Yes, no. Do I think this is a mild stroke or a severe stroke? And for those severe stroke patients, those patients transport them directly to the highest level center in reasonable range. We're also working to educate consumers about the importance of calling 911. There are certain populations where there's a mistrust of the medical system. They may not want to call 911, or they may not simply know that this is a treatable cause. And instead, people want to think about just sleeping it off. Next slide, please. We really think the best comparison for what we're trying to do with stroke is trauma. If you get to a motor vehicle accident scene, the trauma campaigns have been successful in saying you should evaluate the patient on a variety of factors. There's going to be hemodynamic parameters, there's going to be scene factors and mechanistic factors. And if a patient meets those factors, they should go to the most appropriate center. In some cases, that may be a level 1 trauma center that's a little farther away. That's okay. Similarly for stroke, when you assess a patient in the field, you look at their stroke severity. And if it turns out that that patient is suspected of having a severe stroke, and it could be a large vessel occlusion, but also be an intracerebral hemorrhage, they should go directly to the best possible location. Go to the next slide, please. So just like with the trauma patient, where they're triaged and transported and they receive the appropriate treatment. The next slide, for the stroke patient, we're going to do the same thing. We're going to triage, we're going to fix this red box, right? Which is they go to a hospital that's not able to care for them, and they sit there, and that delay costs the patient. Can go to the next slide, please. Now, I'm not sure how many of you saw this recently, but this was recently in the news because of a couple of trials that suggested, and that some people have interpreted this data as there's no benefit to bypassing closer hospital. But I think it's really, really important, and please indicate in the chat if you heard about this. It's really important to look at these details. We go to the next slide. So the first thing, these studies were performed in more rural regions of Europe. They weren't performed here in the US. Most of these patients were more than an hour away from a comprehensive stroke center. What we are targeting first in our campaign is those patients that are 10, 15 minutes away. In fact, patients in the target area, or the sort of the sweet spot, 30 minutes of a comprehensive stroke center, they were excluded in these trials. Now, why were they excluded? Because the way these healthcare systems are set up, they don't bother even having a primary stroke center within 30 minutes of a comprehensive stroke center. It doesn't make any sense. It's better to put the resources into having one big busy center than having a bunch of small centers. But the way that our healthcare system is set up here in the US, we're not that smart. We have every hospital wants to be a stroke center, and that's what this creates. Another important thing is that the primary stroke centers in the RACECAT trial had door-to-needle time. So Dr. Fifi was talking about the importance of IVTPA or IVTNK. These are intravenous thrombolytics, important part of the treatment for stroke. Well, they had these times where they could get the drug in 30 minutes or less. That's a nice target in the US for a busy comprehensive stroke center. There are very, very few primary stroke centers in the United States that can consistently give intravenous thrombolytics in 30 minutes or less. Never mind getting the patient in, treated with intravenous thrombolytic, and out the door in a timely fashion, okay? So I'm just gonna pause and answer the chat here, right? So it says most Arkansans live 1 to 3 hours from a comprehensive stroke center. Yes, EMS providers. Okay, so that's great, and that is fantastic. So again, in that type of situation where you're much farther away, the key is to have the primary stroke centers have very efficient workflow like you're talking about, where you can pre-screen, notify the hospital, and pre-modify that med flight. That's fantastic. So in those situations, when you're 2-3 hours away and have to be flown to a comprehensive stroke center, a primary stroke center is a very important stop. What we're really focusing on is about 70% of the country lives within an hour of a comprehensive stroke center. or in many patients, about 50% within 30 minutes. That 30-minute time frame, it doesn't make any sense. The other important thing is the EMS agencies in the RaceCat trial just transported to the hospital. So think about this. They didn't start an IV. They couldn't establish an airway for a patient that was decompensated. So it's not surprising that some data suggests that if you sit in literally an ambulance without advanced paramedic support, without the ability to obtain an airway or intubate a patient, and then are driving an hour, your outcomes might be worse. That's not the same level of care that many of you guys are able to offer. Go to the next slide. So what are some of the resources that we have made available for the EMS agencies? Well, the important one is the EMS mobile app. I'm going to let this video play. So Faith, go ahead and play that video. All right, thank you. So again, the app is phenomenal. We can go to the next slide. I encourage every one of you to download it. You can get it either on the Google Play Store for Android or on the Apple App Store. And we also have a variety of other EMS resources so you can advocate for the patients in your community. If you go to getaheadofstroke.org/EMS, you can see some of these one-page handouts that we've established and developed as resources so that you can advocate for your patients for severity-based stroke triage protocols. Go to the next slide. So what can you do, right? So you guys are the first contact of patients with stroke. And so it's really important. You are the entry and the portal into the healthcare system, and the entire workflow for stroke starts with EMS. Download the free app. Get comfortable with what the stroke severity scale is that's used in your region. Talk to your peers about these resources. Next time you guys are having dinner together, say, hey, just download the app. That'd be great. You can follow us on social media, including Facebook, Instagram, and X. There are many of us, and we can help connect you with neurointerventionalists like us who've spoken to teams on the ground. Myself, Dr. Fifi, all of our colleagues, we've all gone out to firehouses, to meet paramedics, to meet EMTs, to have local educational events. We love it because the better we can engage with the EMS community, the better our patients do. They're going to come to us anyway. They're going to get treated anyway. There's nothing that makes us happier and nothing that's more satisfying than seeing a patient come in and all of a sudden they're able to move and speak. I'll tell you one story as we finish up. I had a gentleman who collapsed on a golf course and was unable to speak and move the right side of his body. He was having a stroke affecting the left side of his brain. EMS brought him in. They drove past 2 other primary stroke centers, and we did the procedure. We removed the clot, and we were literally just about to do the final set of pictures to take a look at the blood flow in the brain. And the patient said, hey, can I say something? And it was the first time he'd been able to speak since he collapsed. And everyone in the room literally got goosebumps. And he basically said, I think I can speak again. And once you've seen that happen, once you've felt that moment, you will understand how critical this is. We have a variety of different materials. You have Faith's email there. Please send an email along. Please going ahead and going forward. Okay, question and answer. I see a question in the chat, and this is from Brad. And Brad's question is, we need one nationwide certified stroke scale for EMS. Yes, so that would be fantastic. I think that if we could all agree. However, the challenge, as with everything else, is going to be all politics is local. I couldn't agree more. I will say that the performance of the majority of these stroke severity scales is similar, but I absolutely agree. but even just the lingo is different. So what's in New York City where Dr. Fifi works is different from the lingo where I work versus Chicago. But I agree with you, Brad. I think if we could get one, but remember, we can't even get small states to agree on protocols. Now you're going to get the entire country to agree. I will say that one thing that we did do is working with the Office of EMS, the national model EMS guidelines were updated last year. And the most recent revision specifically speaks to the importance of having a severity-based triage protocol for suspected stroke. The other reason why it's hard to come up with a single national model is that just like the example given from Arkansas, Arkansas is different from Rhode Island and is different from New York City. So you locally know your regions better than any national person could. I would have no idea what an appropriate triage for Arkansas or rural Wyoming looks like. I can tell you what it looks like in Rhode Island and southeastern Massachusetts. And so I think that is a big part of the challenge. Happy to take other questions at this time as well.
And if folks prefer to speak and ask a question on your microphone, you can also unmute yourself if you're more comfortable there. And I will say, don't feel pressured to ask one now. Oh, I see we got one in. I'll just say we will also be available, of course, for questions after and can share around. But we've got one more, Dr. Jayaraman. Do you recommend a specific size angio when starting an IV for TPA?
So I think that in general, it's for TPA, but also for doing the CT angiogram, which is the imaging test to look for the large vessel occlusion. So generally, if you can get a 20 or 18 gauge IV safely and quickly, that's great. If the patient's a difficult access and the best you can get is a 22 and you can get them a 22 quickly and get them out of there, that's fine too. But in general, the CT angiograms work better with an 18 or 20 gauge IV.
Yeah, our stroke protocol in our emergency room states to attempt to place two 18 gauge IVs if possible. It's not obviously not always possible, but
Vincent got a thank you.
oh.
And got another thank you in the Q&A. All right. Well, again, if you guys think of questions after the fact, if you can email them along, we can work on answering them. Thank you guys for everything, guys and girls, and everyone for all you do for our stroke patients. It's really important work, and we're really grateful.